I'm Dr. Jeb Hallett, Medical Director and Vascular Surgeon for the Roper St. Francis Heart and Vascular Center in Charleston. I'm with Dr. George Giles, who is the head of our transplant unit here at the hospital, and with this wonderful gentleman, I'm going to call him Lou, who is 93 or 4 years young. 94. Who's had a long history of diabetes and peripheral vascular disease, and in 2007 underwent one of the first bone marrow transplants to save his leg. And initially that did very well for you.
Right, absolutely.
And he's had a good result from that, but in the past year or so, the circulation in his right leg has begun to slip off again, and the pressure in his leg now is below 30% of normal, and the oxygen levels are getting critically low. So we are planning today to do a second bone marrow transplant for him in an attempt to save this leg. I'd like for Dr. Giles to comment a minute about the approach and the safety and the simplicity of the technique that we'll be using to get the blood cells of Lou to transplant into his leg, and then I'll talk a little bit about the technique.
Well, this is a confirmatory trial, as you probably know, utilizing stem cells which normally live in the bone marrow, taking them from the bone marrow and placing them into other tissues in the body. Bone marrow stem cells have what we call plasticity. That is, they have the ability, when they're placed in a different environment, to grow into different tissues. The intent here is to try to retrain bone marrow stem cells, instead of making blood cells, to make blood vessel cells and grow new blood vessels. So my job as half of this team is to actually procure the stem cells from the bone marrow, which is a technique we do all the time in the office, whereby we put a needle into the pelvis and aspirate the liquid bone marrow. And it's a series of needle punctures, but only through one actual scalpel incision in the skin. We redirect the needle in and obtain about half a quart of liquid bone marrow mixture, which is then highly concentrated with this proprietary device that Harvest makes that you now own. We then end up with 40 cc's of marrow concentrate that Dr. Hallett places into the leg to try to restore the circulation.
And the beauty of this technique is we can do it as an outpatient under intravenous sedation, and he can be home this evening. I think we need to keep in mind that this is in the context that many patients who have peripheral vascular disease have angioplasty or stents or more invasive major bypass surgery. Lou has had all of those in the past in an attempt to save his leg, and we got to a point where we needed to do something new, and this new innovative therapy, the stem cell therapy that Dr. Giles has talked about, is our choice now to try to help him. Thank you very much for being a great patient.
Thank you very much for helping.
Glad to do it. Our pleasure.
Thank you.
And we've already looked at this with ultrasound, and we know that there's some blockages through this zone, and there's some other blockages up around the knee. So we're going to intend to inject these cells in the anterior compartment of the leg, around the area of the anterior tibial artery, and right down onto the foot, even to the base of the toes. And then on the medial side, where you see he's had previous bypass surgery, we'll inject additional cells down along this area, along the course of the posterior tibial artery, and out onto the foot. So what I'll do now, and these injections will be about every 1 to 2 centimeters. So what I'm going to do now is just come to the base of the toe and just very simply use this tape, and I'm going to make these injections about every 1.5 centimeters, because this is really an area down here where we need most of our cells. And you'll see these injections will be made with a very small gauged needle, placing the cells into the muscle compartment, not into, but adjacent to the blood vessels that already exist there. But those blood vessels, as I have mentioned, are occluded. I want to space these a little further apart as we come up the leg. So let's do the same thing now on this side. We're going to come across the dorsum of the foot because I'm going to put a little mark at the base of each toe because I want to deliver some cells at the base of each one of these toes. And then Lou will roll your foot this way just a little bit. We really want to come back along this part of the foot, and especially around the base of this ulcer, which you can see here. And again, these injection sites, I'm going to make them about every 2 centimeters. We're going to swing now a little bit more up toward the anterior compartment. As we come further up the leg, you can see the condition of the skin is certainly better. So we'll space these out a little more here. All right, so this will be the course of the injections that we're going to do today for Lou. We do not do any injections on the bottom of the foot. These ulcers are fairly typical of the type that we would see in a patient who has this degree of ischemia. They've certainly not advanced to the point where this therapy could not benefit him, and I think that's an important point. We want to do this before the patient has gangrene and very extensive ulcers. We're ready to go. Dr. Hallett and Lori Bennett were outside the procedure room where the bone marrow transplant is going to be performed. Lori Bennett has worked with me on this clinical trial. I mentioned Lori Egger earlier, who's our nurse practitioner. I wanted to show you a little bit about what we do prior to operation with ultrasound. We actually map out in the vascular lab which vessels are open and which vessels are occluded, and we mark it on this drawing. And that helps me conceptualize or think about where I want to make the injections. I know that this area of the anterior compartment has an occluded vessel, and I know that that's an area I really want to get a lot of cells into. We're not going to inject a lot up around the knee because there are large collateral blood vessels that actually go around the popliteal artery. And then we'll deposit cells in the posterior compartment and out onto the foot. And then Lori Bennett and I see these patients on a regular basis for follow-up. Of course, we're getting the vascular lab, we're looking at the clinical condition. And Lori Egger, our nurse practitioner, helps us with any of the wound care. So this really is a team effort, not only in the operating room, but in the clinic following the procedure.
Oh, yeah. Our photographer is...
So now,
Dr. Giles is beginning to prep the contralateral side now to harvest another 240 millimeters of cells, and then these cells will be taken to the centrifuge for preparation. Just want to emphasize that this procedure is being done with anesthesia and attendance under intravenous sedation and EKG and blood pressure monitoring for safety.
We try to do it through one scalpel incision, and so we've got the posterior superior iliac crest, then you have the posterior iliac crest here, and we kind of can use that as an arc of targets, if you will. So we want a central location we can redirect the needle through. So roughly speaking, right about here. And anesthetize the skin for protocol. He's feeling that, so I know. And some of the subcutaneous tissue we also anesthetize. Trying to get to the periosteum if we can.
This is Dr. Hallett adding comment. We often will give these patients a small dose of Toradol as we're beginning the procedure to block any inflammation and pain. This patient has a serum creatinine of 1.4, so we're giving a half dose or 15 milligrams of Toradol as Dr. Giles begins the aspiration.
Alright, so the syringe has been rinsed. Okay. So I'm going to put it back this way and pull it the other. Alright, so some of these are marks, man. What we're encountering here is some degree of scarring from the previous procedure. back it out a centimeter between aspirations. So we presume we're pulling from a slightly different marrow compartment. That's the rim percentage.
Yeah. $14.
So, much easier than the average.
9.
What anticoagulation is he on, Jim?
He was on Plavix. We stopped it a week ago. He's getting aspirin.
The thing about an aspirate volume is that the first
9.
3 to 5 cc's is where most of the stem cells are. Beyond that, you're entraining a lot of peripheral blood into the sample. What's interesting is I'm encountering some of the previous harvest sites I can feel. And these needles will want to go down into the previous spots. When you have a virgin spot like that, it tends to come back slowly.
It's 10.
What's our volume so far?
96.
Collect 120 cc's from each side. Total of 240. From there on this side.
That is 12.
Dr. Giles now is preparing the right side of the patient for additional bone marrow harvest.
Long reach. You really control
Patient has had previous bone marrow harvest, so Dr. Giles has to work around some of the marrow sites.
The difference here, obviously, is this is the first patient who's ever had a second one done, a second marrow harvest. And it is evident when you put the needles in, these needle tracks, they want to find the old sites, if you will, that haven't fully healed, perhaps. And what I found was that if you entered a former needle site, what you got was, for some reason, a more brisk return of what was probably more blood than marrow. So I made every effort to find virgin sites along the iliac crest, which wasn't that difficult. It was just a notable difference from a marrow that hadn't been harvested before. We'll need to see what the quality of the collection is relative to the first marrow harvest, but in the bone marrow transplant experience for patients who are undergoing bone marrow transplant for leukemia, for example, the quality of the harvest didn't differ substantially, so it should be just as good as the first time around.
Got to slide your clip. Hold your bag upside down and then squeeze the filter. Squeeze the filter itself. There you go. Yep. And now you're going to draw your 60.
tip and the stroke bar that went on it. Each of those was individually manually sharpened and reused. You'll say they got all, more often than not they were all. Yeah, and ergonomically, you're trying to drill a hole with your wrist like this, really, but these T handles. I sedate all of my patients for that. This is easy because you would have a that gets we're sending samples.
So now she's going to take them out, she's going to put them into the machine. She's going to line up the white injection port.
Okay, we're going to transfer the patient to a supine position.
Back-to-back artists.
Yep. See this properly, so just close the lid, hit the green button. Yep.
Small collaterals, don't you?
Just put them in the tray board, yeah. Now you might want to do all the aspirations, but that's just a little easier.
Still give it again, all this,
This will run 15 minutes, so it'll take us about 3 or 4 hours and so on that. So we need to have the patient still under sedation and get back to the patient. So
We'll look here and then the clock.
Marvis marrow? Only indication now,
So you
Marvis
can
marrow.
see there's that, see that white cell line? You just want to fire hose them off the side.
See, I don't think.
Yeah, there you go.
How many
There you
here?
go. Perfect.
173
All the way
years.
around perfectly.
I mean, you really want to put these cells in the
Thank the heaven.
posterior
Been
anterior
long
compartment.
enough, 5 years.
And then actually transfer it
Because
again.
that operating room area
Yep.
knows
Just fire hose it
where
in.
the vessels are, the depth, and then
And then what I'm going to do is just turn it to the side so that you can go all the way into the corner and maximize all the volume.
What's that?
Okay. So now these are going to get transferred up to Tiffany. It's, you can either leave it standing in that
Before it's got a pop, it's got a
the way it is and do them all. Yeah, or you can do them one at a time, whatever's best for
And you
you.
can tell looking at the skin here that this doesn't look so good. I thought this was.
I'm just going to turn this on you, okay? There you go.
I think it's,
That's good.
Good job. I do it a good 3 times just to make sure you get it, yeah.
Depending on the length of it, you know, 8 feet from the center of the port, or 2
you gonna fix the clock?
Mhm.
Is the work order in to do that?
I don't know, it's been like that for 2 days. This is my birthday.
It was like that last week,
Oh, is it?
Friday, so. Can you check, because having been able to look at a clock really helps the surgery. I mean, it helps me sometimes pace what I'm doing.
There's a clock on the monitor right there also.
Yeah, but I can do this.
That's what makes it.
I can still see some of these. Those are the ones you want to just spray them right off the side.
We have those.
Yeah, I would give it another flush just because I can see some cells there too.
Throw water on my face at the next slide.
Yeah.
Normally they're not. You don't know which one to do, either a sham harvest.
Relax,
Just a simple aspect of inside through the same scalpel incision. So that they all come out of bandages. They all come out with scalpel. Some of them have done that harvest, and some of them haven't. But they draw blood beforehand, 40 cc's of blood, which, you know, just looks like blood. You can't tell the difference.
The thing that when I see aspirin, I see this. That's how they get the real thing.
Yeah, the fat globules that are living in the marrow. Marrow is 50% fat, so.
Okay, so now we're going to have her transfer these out.
So and it'll separate out. It'll layer. Yeah, you can see the fat.
Easier.
But we're
Yeah,
gonna pretend
thank you.
you can't tell.
Alright, so Tiffany's going to get her 60 ml syringe and it's going to have a docking device on the end of it.
It's like 10 syringes, so you can.
Or actually, she's going to use her 10 mLs.
That's what
Make it fluid like that.
Yeah. You ready, Tiff?
Opaque syringes.
You got to take that off. Yep.
Then you wouldn't know.
She's going to transfer this up.
You wouldn't know where LCC ended. Unless you were doing 40 different 1cc syringes. Opaque syringes.
Are you, you're,
Taping this, yeah.
taking it.
Yep.
I wonder if these 94-year-old stem cells look like little children or like 94-year-old
up.
stem cells, huh? I mean, what are they?
Well, I put Botox in there before we started.
Can I move around now?
Did you?
Relax them,
Sorry.
yeah.
After that one, I can move around.
After that, she's going to take a
Little
sample
filler.
into that little orange cap vial.
Okay.
First, she's going to mix it up.
Lump
She's
'em
going to
up.
put her thumb
There
on
you
the end
go.
of it and mix it so that. Yep.
So what do we know about old stem cells? They're just old stem
Okay, so
cells?
Tiffany, if you want to put an
They have a
air, you've
slightly
got an air
lower
bubble. Yep.
regenerative
Put your thumb over the end of it.
capacity. We know
Nope,
that
no,
when
you're
we
right.
do
Yep.
colony
There you go.
formation
And just give it a good
assays.
mix.
Uh-huh.
There is some aging,
Back and
but
forth,
not-
so that
not a
we,
lot.
yep. And then we're going to take our half cc sample.
We need to measure telomere lengths on all these.
There you go, you know. You guys are perfect. I'm amazed how happy you get.
Yep, that's good.
And this will go for analysis of cell count.
Correct.
Which I
Yep.
think is what Dr. Goss was talking about earlier.
This is
Okay, gotta get warmed up here.
That
This
was
is the
tasty.
So now she's going to transfer it into these smaller syringes, and these are what he's going to put the needle on to inject it into the leg.
Okay.
laterals. And, you know, as a surgeon, having operated in all these spaces, just like you knowing by feel where you're going through the bone marrow, I know when I put this needle's about the size of the one you would get a flu shot with, so it's atraumatic. So I'm going to ask you now, as I inject these cells, and I'm going to put a CC in. As I inject, I'm slowly moving my needle around in this area because I want to disperse these cells throughout this area. I don't want them just in one little pocket. So, on the lateral ankle over the malleolus, you can see this ulcer, which is really a problematic area. So I want to be certain that around the base of this, we are getting a good injection of the cells. Again, with this small needle, it takes a little time to get that in. We want to mix this a little bit so that we get a good mixture of the fluid and the cells. It's an important technical point. I'm going to use a little larger needle now to inject these into the muscular compartments of the leg. Going down to the bone, just coming off the bone. Injecting some cells, and as we get a little higher on the leg, we'll be going a little deeper into the muscular compartment, which you can see here. The skin is very thick, so it's difficult to pull the skin down and make any type of Z-track for the injection. Generally, it's just best to go into the compartment you're in, back off a little bit. The vessels are always close to the center, and just gradually deposit the cells in that compartment. We're going to come on the medial aspect of the leg now and enter the medial compartments. And again, injecting fairly deep in the compartment. We know that's where the vessels are, at about that depth. Coming here again. And then just depositing the cells as I track out. And just rubbing the area. That usually helps seal the injection site. In the deep part of this compartment, and we're just injecting the cells as we're moving out. We have to keep in mind that the large blood vessels here are occluded permanently. They're calcified. We're not trying to get these new vessels to connect to those. We're really trying to get this vasculogenesis to occur so that networks are connecting with the collateral blood vessels, the small collateral blood vessels that are coming down through the muscle in this compartment. Patient's under conscious sedation, really not feeling this. And what's interesting about this technique is that we'll check on the patient in a few hours, and what we generally find is that they are not having pain from either the aspiration sites or from the injection sites. They really tolerate this quite well. And we're just going to finish up by taking some of this up toward the knee area. We're almost finished. That's the final injections. We've injected 40 milliliters of the aspirate now, beginning in the ischemic foot and working up the leg.